All right. So yeah, let me start. So thank you for having me in your meetings. So I'm Jurgens Staats. I'm a family physician working in Northwest Province. Um, yeah, basically my main interest is in allergies. So asthma is a big part of that. So that's, I guess, why I'm here tonight. I spent some time doing one of my electives at Charlotte Potchefstroom Hospital in the pulmonology ward, where I saw a lot of children with asthma. So it's one of my favorite things to treat. Um, and one of the things that I learned while working in that ward is that, you're working with all these pulmonologists, but they are excellent at managing the basics. They do the basics right, and that covers the majority of our patients. So they don't only do the fancy things well, they do the basics well as well. And that's what I'm doing in my setting, and I'm getting good results of that. So basically, I'm just going to go through definitions, um, touching on asthma and a bit of COPD as well, because there's some overlap, and then going on diagnosis, classification, and management. So just going on, asthma is a chronic inflammatory condition. And I put the inflammatory part in bold because we tend to focus on the constricting part of asthma. Well, if you think of how you should treat asthma, it should, you should focus most of your attention on inflammatory part. So it's an inflammatory condition, usually of allergenic in origin, and it's characterized by a hyperresponsive airway disease, and that leads to constriction, and it responds to a wide range of stimuli. And while COPD, it's more your chronic kind of picture where there's chronic obstruction, but not very reversible. So that's just basically setting it, apart from your asthma. Um, but keeping that in mind, there's a bit of overlap between asthma and COPD. So people might have a bit of both, especially older patients, where they do have mostly COPD. They should have, or a lot of them have overlap as well, where it is reversible. So that's something that we don't talk about a lot nowadays, but there is asthma COPD overlap. This is just basically coming straight from the EDL. Just how do you distinguish asthma from COPD? So asthma, usually your younger patients, history of allergies. It's intermittent, but it's fully reversible. So in between, they're well. Um, and yeah, so that's basically your asthma. While your CPD, more your older elderly patients, your smokers, those kind of people. Also heavy cannabis use, previous TB, um, and then also not much of improvement when it comes to your beta agonists. Um, and also just keep in mind your elderly patients. It's possible for them to develop asthma, but usually you have to think of cardiac conditions. So just quickly, management of COPD, you're going to start them on your Venturi mask. You can give them the salbutamol, you can give the ipratropium, and sorry.
It wouldn't be a Zoom session without either a small child or an animal. You'll be back with us in a second.
Yeah, I'm having the same.
Sorry, I've got three sons. I've got three sons, two twins that are 3 years old. So one just waltzed in here. Um, so I quickly just excuse them. Apologies. So yeah, you can give your bronchodilators, and then your oral prednisone. And then also, if there's increased dyspnea or cough or sputum reduction, you can think of your antibiotic therapy. Oh, it's stuck.
If you just click on the screen, it sometimes comes back again. There we go.
Yeah, so it's just important also this, this is just, also coming straight from EDL, but, just being mindful of picking up whether a patient is moderate or severe, who you should admit, who you should discharge. So Carien will talk a bit more about the severe asthmas. But this is just your guidelines. So you can check your EDL, you know, it's quite a good book, especially studying for family medicine. A lot of the questions come from the EDL. We tend to dismiss it as just a government issue book, but it's quite useful. So just quickly, your management of your acute asthma. So first line management, you would look at, obviously going to give your oxygen, you're going to give your short acting agonist. So you've got two options. So first you can do the nebulizer part. So that's our favorite ones that people like. And I guess for some reason, people hear the sound, they see the mist coming out, and it's got some psychological effect as well. So you can give 2.5 to 5 milligrams of salbutamol or 0.5 to 1 milligram of phenobarbital. Just make sure when you give the nebulizer, your volume should be at least 4 moles. So, the 5 milligrams, it's usually 1 mole. So you have to top it up with 4 moles of saline or sterile water just to make sure that, the misting gets delivered. But also remember, you can use your normal, meter dose inhaler. And people from allergy society, they're more in favor of this, basically because you can give an accurate dose of your bronchodilators. Well, if you nebulizer, I mean, you give that milligrams, but how much is really going into the patient? There's all this misting going in the air, and especially nowadays with COVID, is actually preferable to use a spacer with your meter dose inhaler. So you can increase dose. You can start off by 2 puffs every 2 minutes, and you can increase it by 2 puffs until the maximum of 10 puffs. And remember, we don't, activate 10 puffs at one time. So it's 1 puff, 10 breaths, another puff, 10 breaths, and you continue it like that. Otherwise, you're going to waste it. Also, your corticosteroid therapy, obviously in your acute attacks, you're going to give that. It's not going to start working immediately. It's just for that exacerbation a few hours down the line. And general dose, 1 milligram per kilogram per day, up to a maximum of 40. So you give that about 3 days. You can go up to 5 days. And just remember the question versus oral versus IVI. So a lot of people believe that the IVI works better, but there are a lot of research that has been done on this, and actually the oral works just as good as the IVI, corticosteroids. So if you've got the tablets the patient is able to drink, you can give them the tablets. It's gonna have the same effect. You only taper if you use it for more than 2 weeks continuously. Then you cannot just take a patient off it. So that's quite important to remember. Also, then your ipratropium bromide. So nowadays, I know in Northwest we don't get the salbutamol on its own, so they made a combination. So your Combivent, there's lots of products, but it's a combination. So that's on board already in your nebulizer. Then additional therapy, if that's not working, favorite teaching with us is IV magnesium sulfate. So if you're adults, you can give 2 grams over 20 minutes. For children, it's 25 to 75 milligrams per kilogram. Some people bring up the poisoning or the overdose. But if you compare the 2 grams that you give to what we give to our patients with preeclampsia, I mean, we give about 14 grams of magnesium sulfate, and then we check them. So there's no real big concern in terms of side effects from magnesium sulfate. You can also nebulize that, and magnesium sulfate is quite readily available in all our clinics. Because we do maternity in our primary health care, it's available all around. You can also, use IV salbutamol if you've got that in your setting. IV aminophylline, that's something that needs to be monitored in your ICU. Then don't forget your adrenaline. These moribund patients coming in respiratory failure, IMI adrenaline is quite safe. Just don't confuse IM adrenaline with IV adrenaline, because IV adrenaline, like we said, only give that to dead people when you're resuscitating. IM adrenaline is quite a safe drug, so you can give that without worrying that you're going to cause a lot of problems for your patient. Then also, these are the guidelines that we use when decide whether there's a response or no response. with adults. So that's where your peak flow comes in as well. And I'm going to spend a little bit of time on peak flow. I hope it's not too basic for you guys, but you know, in our area, it's not really done. Where there's peak flow, you know, meters everywhere, but it's not used. So peak flow meter, you know, like I said to one of my patients today, it's one of the truth tellers that I use to actually get a nice, you know, estimation of where they are at. So this is my take home. So I'm going to give it you now at the middle of the beginning of my lecture, is that you cannot manage asthma without a peak flow meter, and it's available in primary healthcare. You know, very easy to use, um, available and easy to interpret. So basically, you know, you've got your peak flow meter, you've got a marker, so you use it to the bottom of the numbered scale. Ideally, patients should stand up and take a full deep breath, and then put the mouthpiece in their mouth and form a seal. And then they must breathe out as hard and as fast as possible. Obviously, trying to keep their fingers clear of the skull, because that can, you know, block the skull from moving. And then you're going to read your result, and then you move your marker back to the bottom and repeat it twice. So you're going to take 3 readings, and you're going to take the highest of the 3 readings. So for me, I find it much easier to have my own peak flow meter so that I can show them, because it's much better when you show them versus when you're trying to, you know, to talk them through this. So show them, and then you kind of have to, you know, coach them through this or encourage them, because this is something that needs patient cooperation. Someone, you know, it's not a measurement that's one-sided. So the patient should be able to fully cooperate. So thinking of these 3-4-year-old children, that's not something that you'll be able to do with that. And that's the reason why we don't really diagnose asthma below the age of 6-5, because we can't make them do these lung function tests, peak flow tests, because they're not able to cooperate. Um, so I'm just going to go through a practical exercise just to make sure that we know how to use these things and how to use the graphs. So, you know, you do a peak flow measurement on Mr. H. Buff. He's 40-year-old male. He's got a length of 160 centimeters, and he complains of frequent episodes of night cough and wheezing. So the question is, what is his predicted peak flow rate? So when you look at this chart, you're going to see you have to, you know, first differentiate whether your patient is male or female. Then you have to look at his length. So our patient is 160 centimeters. So you're going to take the bottom, you know, graph that you see there corresponding to his length. You can also take his age into account. So going up the age, the expected peak flows for ages are different in patients according to their age. And then you've got your expected peak flows on the left-hand side. So if you look at him, he's 40 years old and he's 1.6 centimeters tall. So that would intersect at that stage. So his expected peak flow is 600. So his peak flow meters measurements were 300, 380, and 420. So saying that, you know, we take 3 measurements, but we take the highest reading. So what would be the percentage of his predicted peak flow? So that's quite straightforward. 420 divided by 600 would give you 70%. So he's about at 70% currently. So it's very possible that he might have COPD, or, you know, it might not be asthma. So you need to confirm that. So diagnosis of asthma. So first of all, you're going to have your suspicion based on symptoms and signs. You also have to consider differential diagnosis. So for example, COPD, is this bronchiolitis that the child has? Is it viral infections? Are there any associated factors? So looking, you know, especially because it's related to allergies. So does the patient have any, you know, eczema? Is there any history of allergic rhinitis? Are there any other allergies associated with that patient? And then you're going to seek objective evidence. So that's where we have to test for reversibility. Now, in the ideal world where we have all the resources, we use the spirometry. So I'm sure in the Eastern Cape, it's similar to Northwest. So we've got a spirometer at Potchefstroom Hospital, which is broken. And then we've got a spirometer in Klerksdorp Tshepong Hospital. And that's basically what we have access to. So you cannot send all the patients there. So there is a way of measuring it with your peak flow meter. You've also got your optional tests. So you can, instead of looking at reversibility, you can try to induce asthma. So if someone tests, there's no reversibility, but you're still suspicious, you can do like an exercise stress test. So you make them, climb stairs for 5 to 6 minutes, let them rest for 50 minutes, and then, repeat your lung function test and see if there's a certain degree of deterioration after that. In tertiary settings, you can also do your methacholine stress test when you also induced like a bronchoconstriction. And then your fractional excretion of nitrous oxide, but that is also actually more in an academic setting, not even diagnostic, that we use regularly. And also you're going to review your response to the appropriate treatment. So like I said, these young kiddies, we cannot actually accurately diagnose asthma with them because we cannot do these tests because they're not cooperative. So we still might have a suspicion that they do have asthma. So what we do for them is that we then, presumptively start them on asthma treatment and then follow them up and see if they really are better. So if they don't have wheezing anymore, if they don't have night coughs, all the symptoms associated with asthma. And then that would be a confirmation or preliminary confirmation of asthma. So when they reach the age of 6 or 5, when they are able to cooperate, you can do the objective tests. So for us in primary healthcare, you can use your peak flow meter, and like I said, you use the highest of 3 results. And then you're going to give your inhaled salbutamol 2 puffs via spacer and wait for 15 minutes. You can also nebulize them if you've got the medication and the neb masks with you. And then you're going to repeat this. And this would then be labeled as a repeat peak flow. And you're going to calculate the percentage response. And if there's a 20% difference, then asthma, with what I just said, we've given him, the salbutamol inhaler, and 30 minutes later, repeat the peak flow measurements. So his measurements are 500, 590, and 520. So the question is, does he have asthma or not? So we're going to work that out. So he used to have the 420. So if you subtract that and then divide it by the 420, there's a 24% difference. So in this case, you can then confidently say that this patient does have asthma and they should be on treatment. So remember, this is also coming from our EDL. So there's a difference in classifying asthma. So this classification basically is for when you first identify asthma, when you first diagnose asthma, because you're going to use this in terms of your stepwise treatment, what you're going to use for your patients. So this is only done the first time. When you follow up your patients, you're not going to classify them as mild persistent or severe persistent. And that is a once-off classification. That's just to help you to decide where you're going to start off. So that brings us to the GINA guidelines. So GINA is the global initiative for asthma, and they've got a stepwise treatment. So obviously, if you're intermittent, moderate, you're going to start with step 1. But if this is the severe asthma, you're probably going to start at step 3 or step 4. And then you can step down if it's under better control, but you're not going to start off just with a step 1 if you diagnose a patient with severe asthma. Also, a nice tool to use when you're monitoring your patient is asthma diary. So you can look at you can give this home to them. And, Allergy Foundation is a very nice resource to have. So you can go to their website. They've got nice resources. They've got action plans. They've got a lot of free resource things for us to use. So you can give this to your patient and they can, do this and come back to you the same way we do diabetic diaries. And that will give you a good idea, how their asthma is controlled. Did they take the controller for that day or did they not? And it's also a nice education tool that, if they haven't taken the controller for a couple of days, but they had an exacerbation, it's good to show them, listen, look here, you're not really believing in this controller, but you can see the results now. So this is how we classify asthma on follow-ups. So asthma is either controlled, partly controlled, and uncontrolled. And that is just based on daytime symptoms, limitation of activities, nocturnal symptoms, need for relievers. So, a lot of parents has got this belief that my child has asthma, they should stay at home, they should not do any sport, which is one of the first things that I counsel them on, is that any child with asthma should have exactly the same life and opportunities as other children. So if they are not able to, to play with their friends, to do sports, all those things, that's a sign that it's not controlled. So that's how you're going to assess your patient for each and every follow-up. And that's how you're going to classify them after you've diagnosed them and put them on treatment. So patients with poor asthma control, you have to look at a couple of things. So first of all, it's poor inhaler technique. So I'm running an allergy clinic at Potchefstroom Hospital at the moment. So my patients by this time know that each and every time they come to me, they bring their inhalers with them. If they don't bring them with them, I'll write them the script and they're going to go to the pharmacy and they're going to come back to me and I'm going to check the inhaler technique. And inhaler technique is one of those things that I'm still amazed in the various ways that people can get it wrong. So important. Also, patients come today, they do it perfectly. Next time they come, asking to do it again, they get it wrong, or they got some misunderstanding in terms of how to use it. So inhaler technique is something that you have to check each and every time when you see your patient. Then
Jurgens, going in and out.
adherence.
Jurgens, sorry, it's Madeleine here.
Tell you straightforward that I don't like the brown pump. It's not doing anything for me. When I get short of breath, nothing really happens. So I put my trust in the green or the blue one. So some people, they tend to, they'll salbutamol.
Sorry, Jurgens, can you hear me? It's Madeleine here. You just had a little bit where the sound was going a bit poorly. I'm not sure if you can hear me.
I can hear you now, yes.
Yeah, sorry, we actually heard everything you said, but your reception was a little bit poor for a bit. Your voice was getting a little bit distorted, but we did get most of what you were saying. So I think we're still on board. I think your internet might be going in and out a bit, but I'll let you know if your voice goes away completely. Just listen for me.
Okay, sure, no problem. So so there's just that constant just checking that they know what pump is used for when, constant checking that they know the technique, and that's about 80% of getting good results in asthma. It's as complicated and simple as that. Then obviously, if there are exposures or triggers, factors at home or at work, so people getting occupational exposures, thinking of a baker's lung, people working in bakeries, people working in spray painting industries, these things can exacerbate the asthma. Then the presence of reflux. So if they've got heartburn symptoms and all those things, it can also irritate, the respiratory system. So you have to manage that. Rhinitis and sinusitis, I will discuss in a little bit more detail further on. It's quite important. And then the use of medication, especially you get specific patients that react to aspirin. So you get your Samtus triad where they get nasal polyps, asthma, and exacerbation by aspirin. Also your NSAIDs, and then your patients on beta blockers. And then you get other, medical conditions that can also confound asthma as well. So I'm just going to quickly go through your inhalers. So obviously, it's very important that our inhaled corticosteroids, that's the main thing. That's what we should, check constantly, that they understand that they are using this to prevent your patient from getting an acute asthma attack. Now, we love the Bakelite. It's freely available, but we should not, ignore the budesonide. So in terms of strength, the budesonide is just as, as a corticosteroid is the same strength, but the Bakelite has a half-life of 8 hours, while your budesonide has a half-life of 12 hours. So in the pulmonology ward, they would usually use that as a step up, as some sort, just because you get better coverage from that. Incidentally, I went to our pharmacist and they checked, and the budesonide is actually cheaper than the Bakelite, and you get more puffs from a Bakelite inhaler. So I don't know why we actually just put everybody on Budaflam anyway, but yeah, that's just, if you've got both in your setting and the patient is not controlled on the Bakelite, you can actually use it as a step up in inverted commas. Then our favorite Astavent patients love them, but just remember the side effect profile. So because it's a beta agonist, you can get tachycardia, patients can get tremors, they can get headaches, they can get irritability from that. And then, patients tend to abuse them because they don't want to use the inhaled corticosteroids. So they rather... Hello, can you still hear me?
Yes, we can hear you.
Okay. So yeah, so they tend to, use that 7-8 times a day rather than using the inhaled corticosteroids, because they say it gives them relief. Yeah, so just going through your inhaler technique, very important, Prof. Mike Levine at UCT, he's got these videos on, if you look at the Allergy Foundation. So very important to make them understand that one puff at a time. I call it double clutching, where patients just go or whatever, and then they inhale that. So you're actually wasting one puff. So you're going to take one puff as you inhale. So there are a couple of ways of explaining that to the patient. It's nice to have your own asthma pump as well. I've contacted Cipla at one stage because they, the majority of our inhalers come from them. And they promised me you can get these teaching devices where they'll give you a meter-dose inhaler, but it's basically water or mist that comes out, just to show your patient how to use that, if you can get access to that. But once they inhale it, they should keep it inside for at least 6 seconds, and then exhale through the nose. Yeah, so you have to check that. And as much as the very young children have difficulty with the technique of using an inhaler, also elderly people, I found them actually more difficult to get them to use the right inhaler technique. So if you can show them, it helps. But if they really struggle, the only way is a spacer. So, we know all about the bottle spacer. Prof. Heather Zar at UCT, she pioneered the whole plastic bottle spacer. And they've done research on it and actually found that they work just as well as the commercial ones. You can also, if you don't, it's quite laborious cutting through the bottom of a little Coke bottle. They're quite tough. You can also use a paper cup. It's very easy to outline the shape of your inhaler on a paper cut and cut it out with a surgical blade or something, and use that as a form of a spacer. That also improves the control. But ideally, if a patient can use the direct method, that's the preferred way. Then coming to United Airway Disease. So the theory is that what happens in the upper airway, affects the lower airway. So allergic rhinitis occurs in more than 80% of asthmatics, and it's often not diagnosed. And rhinitis more often precedes rather than follows the onset of asthma. So if you can look at this graph, and this graph was from a lecture. Also, UCT has got these online allergy lectures. So if you go to their site, I've got the link at the end of my presentation. You're welcome to go there. There's lots of resources there as well. But if you can look at how asthma is controlled versus when people are treated for their allergic rhinitis, you can see there's quite a dramatic improvement of management. So when you examine your asthma patients, always look in their noses, ask about rhinitis kind of symptoms, because it's likely to be there. And if you're not managing that, you're going to struggle to really control the asthma. Which brings me to examination for our allergic patients. So a couple of classic signs. So these mannerisms that they've got, the twitching of the face, the nose, the allergic shyness, these dark rings under the eyes, the Denny Morgan lines, so the lines that you see here. And then this one we call the allergic salute. So basically they rub the nose all the time, and because of that rubbing there, they get this nasal crease that forms around there. Also, this kid is coming in, mouth breathing, open mouth. And when you look in their nose, you're going to look at the inferior turbinates, and you're going to see pale, swollen turbinates. So they look quite palish, whitish when you see them. So, you know, in like the last 9 years that I've been working Northwest, these are the products that I've seen on our shelves. Unfortunately, for the last 6 months, we haven't had any of these available. So that's quite a problem, you know, in terms of managing your asthma. But, you know, any of these should be just as good as the other one to use. Just remember Iliadin, that's still available on our shelves, but Iliadin is a decongestant, and just be careful. The other term that we have is the oxymetazoline. It's the same. It's just labeled as oxymetazoline, but you know, you get rebound nasal congestion. So that's not to be used for more than 5 days. So that's not something that we ideally put our patients on and send them home. Also, saline, saline washes. So basically, you know, you're going to irrigate your nose. So lots of, commercial products around, but we do have the saline nose drops available. But basically,
Jurgens, we have lost you. Can you hear us? We can't hear you at the moment, and your screen is frozen. I think we might have lost him even. I'm not even...
just washes off the allergens from that mucosal membranes in your
sorry, we
turbinates.
Jurgens, can you hear me?
I can hear you. Am I breaking up again?
Sorry, yeah, we missed you just as you were to say about the saline drops. We didn't hear the conclusion. You froze up for a minute. So you were just telling us about whether it's effective or not.
Okay. So yeah, you know, basically, you know, what it does, it washes off the allergens from that mucous membranes, because remember, there's a lot of mast cells in that inferior turbinates in your nose, and that just washes off the allergens that these patients are exposed to. So very nice, very accessible, treatment without a lot of side effects that you can prescribe to your patients. So for now, in my setting, I prescribe the saline drops to my patients, and the ones that can afford it, I write them a private script for the flow mist. But yeah, something that you can definitely advise your patients on. Yeah, so coming back to GINA updates. So what they found globally is that people, like I said, they tend to abuse the, your beta agonists. And what happens is over time you get downregulation of your beta agonist in your lungs. And what has happened is that you get downregulation, and then at one stage patients get a severe asthma attack, and they run for their Astavent, or they run for their formoterol or someterol, whatever they have, and it's not working. because now they've got this downregulation. Because, like I said, there's this fixation on bronchoconstriction, where the pathophysiology lies in the inflammatory process of asthma. So for adults, GINA is actually now suggesting that even in step 1, when a patient, use a PRN salbutamol, they should follow that with a PRN inhaled corticosteroid, just to keep that inflammation in check, to make sure that that downregulation is not happening. So that's just the latest from GINA. Obviously, when you're going to step up, so you escalate by 1 step of the GINA guidelines of the algorithm if the control is poor, and if you've got no other factors identified. So obviously, if you identify poor technique or poor compliance or some other thing, you're going to sort that out first before you're going to step up. Stepping down is a little bit more complicated. A patient has to be well controlled and very good lung functions, at least for 3 months or more. They have to have less than 2 daytime symptoms a week. You can look at all the criteria for asthma, which is controlled. It comes up as that. So it must be controlled asthma for 3 months with normal peak flows or normal lung function. Then you can step them down. So special circumstances in asthma. So exercise is the first one. So you can get exercise-induced asthma, and it's also one of the features that, the asthma probably not well controlled. So people, sports people should be able to function well. But if that is a problem, you can advise them to take inhale a beta agonist before they go, partake in their sports. Just remember, if they do it professionally or they do it competitively, salbutamol is one of those things that, might be seen as an illicit or sports enhancing drug. So for patients that truly has asthma, they might need a letter from their doctor just to state that this patient actually has asthma and they need it because it's for health reasons. It's not for performance enhancing reasons that they are taking it. Then pregnancy. The progression in asthma and pregnancy is very unpredictable. They might worsen during the pregnancy. They might actually become much better during the pregnancy. But, our epileptic patients, it's ideal for these patients to be really controlled before they fall pregnant. So I know in a lot of settings that doesn't really happen. But if you've got a patient now, she's childbearing age, and she wants to have children, then you've got an opportunity to tell her that it's really important to manage this asthma. Menstruation, some patients can actually have exacerbations during the premenstrual period. And that, for that you can, if they know their cycle, you can increase the dose of the inhaled corticosteroids, or they can go on oral corticosteroids about 2 or 3 days before, the menstruation starts. And just to avert that exacerbation that they might have. Elderly patients, remember, we're not going to give them, it's not ideal to give them these pulses of oral corticosteroids, because now, they've got bone density problems, they've got chronic diseases, they might have diabetes. So, they've got lots of comorbidities with interactions. Then, nocturnal asthma, some patients actually only have nocturnal asthma. So it's one of the things that, if they've got night cough, it's a sign that they're not controlled. But in some patients, that's the only symptom that they have. And if you were to be present at that time, you can see a quite clear deterioration of their peak flows. So that's one of the things. And then cardiac disease and hypertension, just remember also your corticosteroids, especially the oral ones, they cause fluid retention, and overload. So these patients, ideally that, we send them on maybe to a high level of care where they can be monitored better. And diabetes mellitus, obviously your corticosteroids gonna, increase that. Just remember the inhaled corticosteroids, not as much issue as the oral ones. And ideally we don't give that a lot to our patients. That's not our go-to drug. That's just
Jurgens, can you hear me?
In severe,
Okay,
acute
Jurgens, sorry, we
attacks.
lost
Or
you again just for 2 seconds
also
when you were.
important foundation.
Jurgens, can you hear me?
Enough if you.
Jurgens, hello, sorry.
Yes, I can hear you.
We lost you with the diabetes. We lost you at diabetes.
Okay. So yeah, diabetes, like I said, also your oral corticosteroids can increase your blood sugar levels, so it might be difficult to control your diabetes. So I'm not beating on a drum against your corticosteroids. Inhaled ones definitely not something to leave out. It's just when you give these pulses of your oral corticosteroids that you have to be mindful in these patients. Then a written asthma action plan, something that you can give your patient to take home, something to make them aware. So that's where you can give them a big flow meter to take home if they are with it enough, or you can gauge your patients to know that this patient should be able to interpret their peak flow meter measurement, and this will just give them that warning that I think I should go to the hospital now and have be treated before it becomes a severe asthma attack, which will, cause the patient to be in hospital for weeks. Well, when they can come, you can give them their NEBs, you can give them magnesium sulfate, you can give them the short dose of oral cortisone, and they're fine and they can go home, if you catch it early on. So this is just also an asthma action plan that's available on the Allergy Foundation. So everything is there. You can just fill it in, and the patient can self up to a stage where they will be then aware of things are not going like it should, and then I should go to hospital, because that's the problem. We don't want patients showing up, at the end of asthma. We should, motivate them and educate them to come to us before things turn really bad. And yeah, that's my 5 cents. Carien will talk, about the more intricate and more detailed things. But doing the basics, right, is really, really very important in asthma. And like I said, I'm getting really good results of that, just doing the basics right. For the rest of it, you can dig deeper. Thank you very much.
Thank you very much, Jurgens. That was very helpful. And it feels like we've got a nice practical approach there for asthma. I've actually been communicating with Carien. So Carien was going to take it more onto the level of programs, public health, and 10-point plans, specifically based on epidemiology in South Africa and managing severe asthma. And that actually needs a bit of time. So we've actually agreed to create a separate session. I'll chat to Dylan whether there's place within the normal WSU timetable. Otherwise, we'll fit it in through the RUDASA, the rural health onboarding side of things. So we're going to create a follow-up session that's going to look, and then probably some more cases and practical examples. Particularly interesting is this change that is coming about, that we are using this thing of following up your salbutamol with the beclomethasone. We've just been discussing it this morning at our department as well. And here at CMH in East London, we actually have available the budesonide formoterol combination in the public sector. And that's becoming now. So they're using that. They're prescribing that in my department in step 1 as their, so instead of having a controller and a reliever, you're just using that as a reliever, already a combination formoterol. And so there's very interesting things happening in the world of asthma. And I think we're going to have another session to really focus on actual a public health approach for that. So I'd like to open it now, the floor for questions. If there is anybody that have got any questions or comments, I'm just going to remind everybody, please, could you put in the, oh, look, Dylan is just saying there's definitely space for another session. We're very keen on this topic. I'm going to ask everybody again, please do put in the chat just who you are and where you're from and what you're doing, especially if you're just appearing as iPhone or some anonymous misnomer. We'd love to know who's on the group today. It gives us an idea on what target group we're talking to. So please just in the chat, put your name, where you are working and what you are doing. I see we even have some students on the chat, which is great. And then I'm going to ask if there's any questions or comments from anybody in terms of Jurgens' presentation? I am also just interested in the Eastern Cape, what access you guys have in terms of things for allergic rhinitis. That was one of the things that I was wondering about. Oh, I do have one. I do have two questions actually, but we'll see first if anybody else has got questions before I take the. You mentioned the magnesium sulfate as an inhaler, or using it as a nebulizer or inhaler. I've never done that before. Could you just give a bit, the print was a bit small. Could you just describe how you would do that if you wanted to actually give it as an inhalation?
Yeah, so you've tried all these things, and in our emergency medicine course, so we do basic emergency skills training in Northwest. One of our favorite drugs is IVI, but you can also absorb that via nebulizer, because you also get the dosage from that. So definitely not your first step, but then one of the things, especially thinking rural, thinking our clinics, that's my experience going to your emergency cupboard and not finding the salbutamol, not finding the things that you need. Sometimes your magnesium sulfate generally always available because of the possibility of preeclampsia in patients. So definitely an option if you don't have anything else that you can use.
And then I just had a question around infection control and the peak flow meters. So one of the issues, we don't have peak flow meters, which is ridiculous. I'm at a large family medicine department. And then one of the issues that was brought up today is that, I don't know who told who, but that because of COVID, there's an issue around doing peak flow testing, obviously within the consulting room session. So there was that question. Well, I had one question around that. And then just a second question around the practicality. Are you using reusable? Do the patients have their own peak flow meters, or do you have reusable, or do you have to clean your mouthpiece every time and your systems just around that? I think peak flow management, when I worked in the UK, peak flow was standard part of asthma treatment. And I've been quite interested to see of how few clinics and hospitals actually have peak flows easily available. And I agree with you, it changes your management of asthma, becomes much more scientific if you can actually do a peak flow.
Yeah, so in terms of infection control, practically I clean it in between, and I clean it when my patient leaves, and I clean it when the next patient comes. I actually clean it twice, just for the next patient to come in and see you cleaning it, for that purpose. But ideally you get this cardboard, actually very cheap. Yeah, I mean, I think it's R1 something per this cardboard list, but yeah. In terms of giving it to a patient, that becomes the patient's property then. It's like, some of our diabetics, we give them the glucometers. So yeah, we've got, in my clinic, I work in a CHC, we've got about 5 or 6 at any time. There's one in each room. So quite available. And I guess, we can order more, although it's not something that you deal out like sweets. Your patient has to, when you give it to a patient, they should be able to use that. And also in terms of COVID, I would, luckily, if you've got a spirometer, they usually got a filter in there, because that's when you do spirometry, you do the inhalation part as well. While with your peak flow, you just do the blowout part. So, yeah, not to say that it's 100% safe, but yeah, we do the best we can. I clean it every time in between, twice.
Thank you very much. I'm just checking if there's any hands up. There are no hands up at the moment. Carien, could you give just quickly say hello and give us a quick teaser on what you'll be covering in the next session?
Hi, everybody. Yes, I don't know, can you hear me?
Yes, yes, we can hear you clearly.